Guess what time it is, friends? Good evening. It's 5 o'clock Central Time, which means 6 on the East Coast, 4 in the mountains, and 3 on the West. And there is one place that you are supposed to be right now, and that is Fertility with Fink. And that is me. I am Dr. Randy Fink, and I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. Tonight, I am once again live from Panama City. So it looks like I am sitting at somebody else's desk. I'm not sitting in front of my usual brick wall. That is true. Thank you for noticing that. And I'm, in fact, wearing a tie. You know what? So I cleaned up my act just for you. So hopefully hopefully you still recognize me, wearing a tie. I don't actually really enjoy wearing a tie most of the time, to be honest, because I feel like it's adding sort of one more layer. It's a nice sort of more formal look. And so I'll do it sometimes when I have to. But frankly, it's nice to just kind of sit here and be with all my friends. This is the place that I look forward to being at all week long. Our Tuesday evening get together. And if you're just joining, thanks so much for being here. We're part of the First Fertility Network, and we are here every week at this time to answer all your questions about women's health and fertility, all the things that are important to us. So who do we have? Hello, Kowser and Angela Sack. Good to see you, Rosa. Thank you. Oh, and the tie suits me. Thank you very much. I appreciate your kind words. Mimi, good evening. Lexi, hello in the Carolinas. Hi, Florida girl. Big Boy Pants Golf, good to see you. And looks like Bont Just Lindsay, I think is what that says. It's good to see you too, Angela, here. So we've got a bunch of different streams going. We've got my Instagram, which is Randy Fink MD. We've got New Life Fertility's Instagram right here. And we have a few right in the middle here, and that's Facebook, YouTube, and LinkedIn. So if you've got questions, throw them this way. Let's see if we can get to them. I will say, I hope your week has been, or that your weekend was very special. I had a birthday. Believe it or not, I turned 21. Yes, it's the truth. It is the truth. I turned 21 years old. I finally had my first sip of wine, and it was. I really thought there was going to be more to it than that. But I went out of town. I went to my high school reunion up in Annapolis, Maryland, and I saw a lot of old friends and a lot of folks that I just haven't seen in a very long time. And it's so interesting how. All that pain and all the, sometimes you have good memories and sometimes bad memories, but you carry all these memories with you wherever you go. And a lot of times you look back and you think about pain, and then you get together with all these people who shared some of those, really all those same experiences with you. And now all the cliques are gone, and all the people are nice. And it's kind of a miraculous experience. If you've lived through it, if you've done it yourself, you know what I'm talking about. It was great to be at a high school reunion and to celebrate my birthday there, my 21st birthday there. So I've got a little bit of a scratchy throat. If you hear me clearing my throat or taking a drink, that is the reason why. Let's see if we can dive into some questions here. Florida Girl says, do you recommend a modified natural for an endometriosis patient over a medicated cycle? Well, I'll tell you. There is some evidence on that because we try to make decisions about what to do in these scenarios based on not sort of seat of the pants, what feels good, but really rather on what does the data show us when we study these things. And the answer to that is that a modified natural versus a medicated cycle for an embryo transfer are really said to be equivalent. And the presence or absence of endometriosis does not change that. So endometriosis, of course, is the process where that lining of the uterus that normally sloughs off instead works its way up north and implants around inside the pelvis. And it can interfere with an embryo implanting. It can do a bunch of different things in the body, but the one that we worry about most when it comes time for embryo transfer is that lining going to try to inhibit the pregnancy from implanting based on the endometriosis. So the more important feature with the endometriosis is that we suppress it for 60 days, and that's using either Lupron or Orilissa or Myfembree. Suppressing for 60 days turns off the inflammatory marker that's caused by endometriosis on the inside and really restores natural fertility to the uterine lining. When you do a natural cycle, you're using your own ovulation, your own natural cycle to produce your hormones for that embryo transfer. So you're developing a follicle in the ovary. That follicle is going to make estrogen. That estrogen thickens up your lining. When that egg gets to the point that it can get released, you ovulate that egg, and that results in turning your estrogen making factory into a progesterone making factory. And that's where your progesterone comes from. That's a fully natural cycle. In a modified natural cycle, we usually do some ovulation induction. We'll use a medication like letrozole to make sure that you're going to make an egg, or at least one egg. We trigger the ovulation so that we know that the egg is being released, and that results in us really being able to coordinate the timing of the embryo transfer. So that's a natural cycle. In a medicated cycle, which is the way they've kind of been doing it since IVF was invented, we are taking all those hormones and we're giving them to you from the outside. You're using estrogen to build your lining. We're giving you progesterone from the outside. So in that way, we're really controlling every variable so that nothing is left to chance. Originally, that was the only way it was done. It was done by a programmed, medicated cycle. And then they started studying the more natural way. And what we found is that, it really, the outcomes are at least as good one from the other. So whether or not you have endometriosis, the natural cycle or the medicated cycle or modified natural should really be equivalent. There is nothing worrisome about being able to, about using the estrogen, for instance. It's not that using the estrogen will result in something deleterious because of the endometriosis. So I hope that answers your question there, Florida girl. Great to see you. Marta, good evening. Hello, Alyssa. Oh, and thank you now for the birthday wishes. I was hesitant to say anything about my birthday because I didn't want people to think that, oh yeah, I'm doing this because I want everybody to tell me happy birthday. So, but hey, I'll take it. Thank you. Thank you very, very much. Lexi says, how long after transfer will I need to be on Neupogen and enoxaparin? So Neupogen is pretty controversial. Neupogen is not something that is generally recommended in most cycles. At some practices, they will use it as part of specifically the level 3 immune protocol. And I believe in their protocol, you stop that as you reach the end of the first trimester. So at about 12 weeks, same thing typically holds true if you're using Lovenox or enoxaparin. If you're using that empirically, which means to say that you're not specifically treating something that you found in your blood, but rather using it just because it feels like the right thing to do. 12 weeks, by the time you're done with the first trimester, you can stop using those medications. Good luck, Lexi, on your embryo transfer. Angela is here and asks, does the estrogen decrease significantly after ovulation? If you're over 40, do you recommend estradiol tabs or patches if cost is not an issue? So what you're asking about is, estrogen does, it sort of plateaus and then eventually it goes down. There should not really be a real significant difference between using patches versus using the pill if you're taking estrogen. And the reason for that is that, well, we absorb estrogen pretty well orally, but we also absorb it pretty well through the skin. There are, in classic IVF, that is to say, sort of in the olden days, the patch was much more uniformly used because they thought that the absorption through the skin was more reliable than what happens when you take a pill. The pill is much cheaper. It's easier. It doesn't create rashes or little adhesive patches on your skin. It doesn't irritate the skin. It doesn't come off if you sweat or exercise or if you take too vigorous a shower. Frankly, I'm a fan of the pill, but there are some people who would prefer a patch. Really, ultimately, it depends on a personal preference. Now, that said, I am not aware of any evidence that shows that age relationship to whether you're using a patch or a pill is correlated with outcomes there. So I know in the practice that I joined here in Pensacola, Dr. Rips typically has been using patches for, since he's been doing the process of IVF. And so that's what they use most of the time. If cost is an issue, we go to pills because I always used pills previously in my training. So I think either way is fine. If you have a preference, you can ask for it with your doctor. And really, there is no evidence that one is superior to the other. So nobody should tell you no. All right. Plant honeys. Hello. I had a laparoscopy in May, followed by 3 months of Lupron. So somebody put a camera in through your belly button, looked around, and found that you had some endometriosis. And they opted to treat you or to suppress that with Lupron. I failed a medicated embryo transfer in August, and I'm starting to have symptoms. Is suppressing with Orilissa for a month a good idea while doing immune testing? Okay, so let's see. The laparoscopy and the diagnosis of endometriosis was in May, and then you did 3 months of suppression. So the data tells us that 8 weeks or 2 months is fine. You probably got one shot of Depo-Lupron, which lasted you for the whole 3 months, and that's a fine thing too. We really think that suppression probably lasts for about 6 months. Now, if you are starting to get symptoms again, that is to say that you're starting to get some pain back, then I would say it is a very reasonable thing to do to think about suppressing with Orilissa while you're doing some other testing. Is there good evidence on that? And I would say no, because that particular scenario is kind of nuanced to your situation there. So it's a hard thing to really study. But continued dosing of suppression, especially when suppression might be wearing off, is generally not a bad thing. So you use suppression from like May, June, July, and now August, September, you're at 3 months. I would say there's little harm to taking the suppressive medication as long as your insurance is covering it, right? Because that medication is really freaking expensive. There is, in fact, a coupon that you can get online for Orilissa, which makes it $5. So usually if your insurance is requiring a prior authorization, they may make you get that authorization anyway. But then if you have a $50 copay or something on that medication, use the coupon because it's $5. And that's a pretty good thing. Hey, Amber, it's nice to see you in Gulf Shores this evening, and hello to Adge 1028. Gradle, hello. And Rosa says, I'm 36 weeks. Oh my gosh, Rosa, I cannot believe that you are 1 month from your due date. And that is just incredible. I bet it's really gone by fast. Actually, it's gone by fast for me. You're the one who's been pregnant and can't sleep at night and everything else. So maybe it hasn't gone by fast for you. But Rosa is 43 and wondering if I should opt for induction of labor if I don't go into labor by 39 weeks. My provider will give me the option, but I'm with a non-ready cervix. So yes, you are correct there, my friend, that you want your cervix to be ripe before you get Pitocin that makes you start having contractions, right? Because Pitocin is a synthetic form of the same hormone that your own pituitary gland makes. And I'm pointing here at the head because it comes from the pituitary gland at the base of the brain. That oxytocin medication is what makes the uterus cramp, It's what makes you have uterine contractions. Pitocin is synthetic oxytocin. And so when one's labor needs to be augmented as a result of just kind of petering out or having contractions that are not strong enough, they will use oxytocin or pitocin through your IV. Now, oxytocin used to be something that we would use kind of coming out of the gate to make people have cramps, make people have contractions. But here's the thing. The cervix is the opening to the uterus, right? And if the opening to the uterus, if the door is closed, then all the cramps and contractions here really may not do a whole lot to get that door to start to open. The cervix itself needs to be ripened. It needs to soften up. It needs to thin out, and that's what will allow it to start dilating. And that's how the baby comes out. So an induction of labor in most circumstances now involves doing something for cervical ripening. Cervical ripening is where medication is placed in the vagina with the goal of softening the cervix, the skin of the cervix, and making it more ready to start to open up. Now, sometimes that ripening agent will actually put you into labor. So, that's kind of the process of induction of labor. But I think your question is really, should I do it at 39 weeks? The evidence shows us that remaining pregnant after 39 weeks, in most cases, does not confer any advantage on the pregnancy, as long as the dating of the pregnancy is accurate, meaning to say, well, I think I'm 39 weeks, but really more likely I'm 36 weeks. They may have been off for a little bit. Well, in that scenario, no, it's not a good idea, to do the induction. But in your case, pardon me, Rosa, pregnant through IVF, the dating is excellent. We know exactly how pregnant you are. And so given that scenario, I would say, yeah, I think there's probably benefits to you going ahead and delivering. As we've talked about before, the placenta is an organ, and it's an organ with a fixed life. 40 weeks of pregnancy, which is actually 10 months, not 9 months, the placenta itself starts to wear down. The blood flow going through that placenta starts to get compromised, and bad things can start to happen. So sometime between 39 and 40 weeks, I don't think that there is anything to say, oh, you really need to do it right on that 39-week mark. But between 39 and 40 weeks, I think is a very reasonable time for induction, given that it's an IVF pregnancy. And at 43 years old, it just means that, you've got some underlying vascular issues anyway, just based on age. So go ahead and get the baby out. It is much, much safer to have a baby held in your arms at that point than it is to have a baby held in your tummy. You know what I mean? Rosa, I cannot wait to see what your baby looks like. Seriously. My friend Angela Sachs says, what are your thoughts of the Inito monitor? Do you think it's pretty accurate with hormone levels? So Inito is a brand of monitor, a type of monitor where I believe you test your urine with these testing strips, and it is read by something on your smartphone, and then it creates graphs and actually gives you numbers based on testing of hormones in the urine. So it's more accurate than something like an ovulation predictor kit. I do think that it's interesting. I do think it's unique. Clinically speaking, I don't find it useful for me in terms of fertility. If I'm going to treat somebody for fertility, we kind of do our own monitorings. There are different norms, different values that come from the blood that's really more accurate. But to kind of see what's going on with your body, and just from the standpoint of, gosh, it is pretty fascinating. It's pretty interesting. I do think Inito is pretty cool. My only criticism, and it's not so much criticism, but just observation, is that those strips are expensive. it adds up fast. So if you're going to do it over the course of multiple months just to kind of see what's going on, it does get costly. But it is cool. Amber asks, does the final transfer have to happen at a certain time in the cycle? Meaning while on a period or when the period would be, or can it happen whenever I get the PGT test results back? Okay, so here's what's happening there. We're doing IVF, right? We're making some embryos. Actually, I gotta just throw this in. Alexis just added this on Facebook. Don't use the Anito when you're pregnant because it gives you really wonky levels. Thank you for that. That is appreciated and is actually a very good observation. Okay, sorry about that, Amber. You do IVF, you make embryos. We grow those embryos up to blast. You biopsy those embryos. You wait for the PGT results to come back. So the timing of embryo transfer is not random. The embryo has to go into the lining of your uterus when your uterus is in its receptive window. And that little window is a very narrow window for implantation. So yeah, we do have to time that pretty precisely. So if you're doing a natural cycle, if you're, let's say trying to get pregnant on your own, your time of implantation typically takes place, well, roughly about 6 days or so 6 to 7 days after you've ovulated. So that's the time at which the embryo has worked its way down and is landing in the uterus. And so really what we're doing with an embryo transfer is that we're trying to approximate that same kind of timing. Now we can do that hormonally. We can give you the hormones so that we can control for that environment. So to answer your question, it does happen at a certain time in the cycle. And that's why when we're using a medicated cycle, we're calling that a programmed cycle because we are programming exactly when that is going to be. Hey, by the way, we're about 7 minutes until half past the hour. And if you're just joining and you haven't seen this before, I do what I call the Fink 530 fuzzies. And we'll talk about that again in about 7 minutes. But I just want to give it a little bit of a teaser. The 530 fuzzies are coming up in about 7 minutes. I'm Dr. Randy Fink, and this is Fertility with Fink on the First Fertility Network. Randy Fink, MD, New Life Fertility. We've got Instagram, YouTube, Facebook. We are all over the place right here, and we're very happy to have you with me tonight. Throw your questions out there. Let's see what we can do to get them all answered. Hey to Sharmila and your beautiful baby there at home. Thank you for dropping in to say hi. Abby Kadabi, thank you for being here. And Kaylee, oh, hello, Kaylee. Nice to see you here this evening. Sharmila does ask, why does oxytocin make babies stress inside the womb? My baby got stressed and ended up with a C-section. Well, so it's not so much that oxytocin or that Pitocin causes babies to get distressed, but what's happening is that the baby's inside the uterus, right? And what is the uterus? The uterus is a big muscle, and that muscle has one job, and that's to squeeze the baby out. Well, imagine you're nice and comfortable all in there for 40 weeks, right? And then suddenly your little cocoon starts beating on your head, man. That contractions are squeezing the head and it's pushing you down and you're going towards the light and you're like, I don't know what that light is down there, but I feel like I should be heading in that direction. Well, geez, as the head gets down in the pelvis, it's starting to get squeezed even more. And that's all very normal stuff that happens as a result of childbirth, but it can cause variations in the fetal heart rate. And so when we are tracing the fetal heart rate, we put these things on here, we see those variations in heart rate, and sometimes those variations result in decelerations, that the rate of the heart rate can slow down. Sometimes that happens because the head is being squeezed. Sometimes it happens because the umbilical cord is being squeezed, that the contractions can push against the umbilical cord, which stops blood or slows down blood from flowing from mom to baby. And that can cause the heart rate to drop down. Sometimes the blood flow through the placenta can be compromised as a result of a placental issue, and all those things can cause the heart rate to drop and can make it look like the baby is in some sort of distress. Now, the goal here is that we want to intervene and get your baby out before the baby is truly in distress, right? We don't want to have to snatch a baby from, the jaws of the evil spirits that are trying to pull it away. Rather, we want to, jump in and solve that process before your little baby gets too stressed out on the inside. So that's really what the purpose of the fetal monitoring is. Now, there's a lot of controversy over fetal monitoring, but when the uterus is squeezing on the baby, it can squeeze the head, it can decrease the blood flow in the placenta, or it can decrease the blood flow through the umbilical cord. Sometimes the baby has the umbilical cord wrapped around the neck, and as the uterus squeezes, well, it's kind of squeezing, it's cutting down the blood supply. Sometimes the baby's kind of just sitting here like this with the elbow right on the umbilical cord, and then you get a contraction, and it pushes there, and it can just decrease the amount of blood that's going through the placenta. So that's really what we're doing with that fetal monitoring, and presumably that's what happened that resulted in you having a C-section there. Let's see. I saw a couple of other things. Gradle says, I'm considering going to a big national clinic, not my local clinic. They're a third of my local clinic, and I'm not having the best experience. What things should I be aware of? Well, so the first thing there, Gradle, is that in clinics that are deeply discounted. Now, I would say at first glance, that's a good thing, right? Because I firmly believe that fertility treatment should be available really to everybody without, it shouldn't be without regard to cost, that it doesn't need to be $30,000 for a cycle of IVF. There are places that charge, still even $30,000 to $45,000 just for the cycle monitoring, for the egg retrieval, and for handling their sperm and their eggs and making embryos. And honestly, I think that's too much. It doesn't need to cost that much. In the low-cost centers, you sometimes run into situations where you are not able to reach someone to talk to, where you will almost never be able to talk to the same person twice. And service starts to suffer. In many of those cases, decisions are not made by clinicians, by experienced clinicians with IVF. They're made by other staff members. But and the reason for that is because to continue to be able to offer IVF at that price point, there has to be some cut in the services. So if you are completely comfortable kind of knowing what you're doing and you don't need a lot of extra help, and you can fully trust the system, then that system may work for you. Lower cost does not have to mean lower service. So I know, for instance, where I am now, we charge more than what we used to charge where I used to work, but we also are able to provide a very boutique, nuanced, and concierge kind of service. Yet it's still, on average, 50 to 75% less than what it costs doing it in other places. So cost is an important thing. But service is really an important thing as well. Best of luck there on that. Sharmila adds one other thing here. I was 7.5 centimeters dilated after 36 hours of labor. So yeah, your cervix was dilated. You were moving right along, but it sounds like they wanted to step in and try to help the baby out before things really got out of hand. Jaspal is over here. Good evening and welcome. How much does IUI cost? Well, so let's talk about the differences, excuse me, and what IUI really means. Excuse me for taking a drink here. IUI is usually where we give you some oral medication to make sure that your ovary is going to produce at least one egg. And we monitor you and we trigger you, which tells the brain to tell the ovaries, let that egg go. And then, we prepare some sperm in the laboratory and we place that sperm inside so it has a chance to swim to get where it needs to be just at the right time to maximize the odds of sperm meeting egg. That process is typically anywhere from about $750 to $1,500 in most places. Now, there are practices that charge $2,500 to $5,000 for an IUI. But the national average is, probably around $1,000 to $1,500, including all that monitoring and the sperm preparation and so forth. Well, it is time, friends. It is time for the Fink 530 Fuzzies. And what does that mean? That is where we all intentionally sit here with one another and think about what each of us is having to go through. I want to try to say everybody's name that I can get to here. And because it is very hard to feel like you're going through the process alone. And whether that's fertility or something dealing with your health or something dealing with your family or something dealing with your work or whatever your stressor is, the important thing to know is that there is a community of people standing here together, arm in arm, all of us. And I have a feeling that any one person on this broadcast would do pretty much anything they could to help somebody else that's on this broadcast. So you know what? Let's take a moment to say these names out loud, stand together as a community, and wish everybody the very best of luck in what they're doing. And that's going to Sheila, that's going to Alm, and to Jaspal, to Amber, to Adge, to Plant Honeys, to Rice, to Angela, to Sharmilla and Rosa and the legit Brit, to my lovely mother, Bamagal, Sheila and Jake and M. Giguero, I think that says, Florida Girl, to Alicia, to Abby Kadabi, to Gradle, to Baby Love, and Lama, I can't read what that says. Sorry. To Lexi, to Kauser, to Rosa, I think I said that. Elisa, Alyssa, Marta. If I missed you, please forgive me, but know that you are in our thoughts, and let us put our hands together. Let us put our hearts together. And now, as one community, send out one big positive vibe to everybody out there who is going through something, who needs to know that somebody else is there. Because if you can do that, you just made a difference in somebody's life. And that's a big thing. That's the Fink 530 Fuzzies. Thank you for participating in that little activity. And if you feel like that's an important thing, how about do me a favor? Ask any of your friends, anybody you know, to join in right at, call it 5:28 p.m. next week, because the more people that we have here to send out those positive vibes, the bigger the difference it's going to make. Let's break the internet with positivity for a change, because we are all in this together. All right. Thanks for being a part of that. Alexis says, I've got my first beta tomorrow. So that means some definitely fuzzies going out to you. Misha, good evening and welcome on Facebook. Getting ready for an egg retrieval next week at Pensacola. Well, good. I will look forward to seeing you there. Outstanding. All right. So let's see what else we have. We got a bunch more questions over here. And let me get back over to them. Do you normally recommend getting an iron infusion if your ferritin is 21, trying to get it up quickly to do an FET soon? Okay, so let's talk about iron. Iron is what we use to build our red blood cells. And red blood cells are what we use to carry our oxygen. So, anemia is the process where our red blood cell count is low. And so that's something that we call the hemoglobin, that our hemoglobin or our hematocrit are low. And when we find that we're a little anemic, usually what happens is that your provider will kind of do a little extra digging to try to find, well, why are you anemic? Are you losing blood from someplace? People who have very heavy periods sometimes can become anemic. People who are have certain vitamin deficiencies can become anemic. People who have a little leakiness from, let's say, an ulcer in the stomach or a polyp or a growth in the colon can become anemic. Some people are anemic just because of chronic diseases. It may be because of kidney disease. It may be for any number of things. But if we find that you're anemic, usually the next thing that gets checked is to look at the iron level. Now, the best way to look at an iron level is to look at a blood test that's called ferritin. Ferritin is the better reflection of your iron. You'd think, well, I just want to check my iron. Just check the number for the iron. And believe it or not, for a bunch of reasons, that's not as accurate. Ferritin is the number that we're looking at because it's not just iron that's floating around in your blood. It's your whole body stores of iron. And so with a ferritin of 21, that's a little on the lower side of things. That tells me iron deficiency anemia means that you were probably losing blood from someplace. And so I would say, gosh, reproductive age woman, it probably has to do with having periods or having a little heavier periods, or even, having gone through some time where you lost a lot of blood vaginally or from the uterus. So the easiest way to kind of treat low iron is to start taking iron orally. The problem with taking iron orally is that it can have some side effects. And the worst side effect there is that it can make you really constipated. Iron constipates people. So there are other forms of iron that you can use orally than the standard kind that may be better absorbed. But doing an iron infusion is something that is generally not a standard of care in order to treat a lower ferritin level. And the reason for that is that because when we use iron, or rather when we infuse iron, people can have what appears to be an allergic reaction to that iron. It actually can have a very bad effect in your blood. So there are other types of iron now that may be a little safer. Something that's called venifer, for instance, is a more common way to do that than a simple iron infusion. But really, that's reserved for true chronic anemia that's not getting better with conservative treatment. I would like for your hemoglobin, your blood count, to be in the normal range by the time you do, or pretty close to the normal range by the time you do an embryo transfer, because you need to maximize that oxygen carrying capacity of your blood in order to go to your baby. Because once we get pregnant, right, blood count does go down. It does that by necessity. We become iron deficient. Your baby starts to steal some of your own iron. And there's a couple of reasons, other reasons as well, that anemia starts to show up in pregnancy. But yeah, so we want you to really be as normal as you can before you get pregnant. Zenny has joined us from Miami. Hola, señorita. Thank you for being here this evening. Did I say hello to my mother, by the way? Hello, Mom. Nice to see you. Yes, I'm wearing a tie. I am wearing a tie tonight. And I am live here from Panama City. So instead of our usual location in Pensacola, I've been visiting the Panama City office today. And it's a wonderful place to be. Great, really wonderful people around here. And gosh, this is really a beautiful part of the country. If you live around here, you know it. And if you don't, please come and visit us. We can get you pregnant here. Absolutely, we can do that. Angela asks, excuse me, what brand of prenatal do you recommend? I personally like the Thorne prenatal, Thorne, Thorne, um, because it's pretty good. Now, here's the story on prenatal vitamins. Don't overspend on a prenatal vitamin. If you can look on the internet, right, and you can find that there's a prenatal vitamin there that costs $120, and you would say, ooh, that must be a very good vitamin because it's so expensive. I'm going to buy that because I want the best for my baby, right? Who doesn't want the best for their baby? Well, guess what happens? Most of the contents of that vitamin end up in your urine. You pee it out because we can't hold all those vitamins in our body. So we have very expensive urine in that scenario. A prenatal vitamin has there are a few different variations. One of those variations is not, can this vitamin get your child into Harvard? Because if it was, I would say spend the $120 and get that expensive prenatal vitamin, but it doesn't. It just ends up in your urine. So the Thorne prenatal costs about $1 a day. I think that's a good, $30 a month is a good middle of the road kind of cost for a prenatal. Buck a day is okay. But truly, even the gummies that you get from Target are probably just as good. So some vitamins have a coating, so they're a little better tolerated on your stomach. Some vitamins have some iron in them, so it helps with anemia, but they may also constipate you. Some have a stool softener in there with them. Some of them have some fish oil that's compounded with it. So you may find some little variations there, but at the end of the day, I don't recommend that you overspend on a prenatal vitamin. I have to tell you this. When I practiced general obstetrics, I had prenatal, the basic Thorne prenatal, exactly. I had prenatal vitamin reps, probably about 8 of them a week coming into my office because these pharmaceutical companies recognized that pregnant people were apt to want to pay good money to try to do the right thing for their children. That sounds reasonable and realistic. And so there were a number of prenatal vitamins that, weren't actually covered by insurance that you'd have to take a prescription to the pharmacy and they cost 90 or $100. Gosh, that's a lot of money for a vitamin. I don't believe in that, and I don't suggest that you do either. Until somebody can show me the evidence that says that one prenatal vitamin is better than the other, or that the more expensive prenatal has some more favorable outcome compared to others, I'd say go middle of the road. Nice $1 a day for a vitamin is all you really need to spend. Yeah, basic Thorne prenatal. M. Gigerero. I said it wrong the first time, and I'm sorry. There's just a lot of U's and R's and E's going on there. So sorry if I'm mispronouncing your name. The question is, what supplements can we take to better egg quality? So there is an evidence-based protocol for what can a handful of supplements do to help us get pregnant. And really, this is what it's about. It's about egg quality because our body has a pretty good DNA repair mechanism. So unlike the sperm that comes out today, which was manufactured in his body about 3 months ago, every egg that you have in your ovaries has been there since the day you were born. And so over the course of our lives, the DNA in those eggs starts to become less stable. And that's what results in egg quality issues. The older we are, the greater that issue may be with egg quality. But as I started to say, we've got a DNA repair mechanism in our body. That's the reason why every time you go outside and get a sunburn, that we're not dying a week later riddled with cancer, because our bodies can repair some of the damaged DNA that comes from getting that sunburn. The same thing happens at the level of the ovaries. So what's the point of taking the supplements? The answer is because it helps the body's DNA repair mechanisms to do what it needs to do. Now, I actually wrote a book on that there, and that book is called The Vitamin Victory, and you can get that book. It's an ebook. It's $7, and it includes a coupon that'll get you, I think, 10% off for the whole list of vitamins at a particular vendor. You can go to my Instagram, which is Randy Fink MD, and click on the little link, which is called Linktree, and you will see the link to the Vitamin Victory. But I will tell you, the most important thing that you should be on is, number one, a prenatal vitamin. Why the prenatal vitamin? Well, the micronutrients are important, but also really the most important feature of the prenatal vitamin is the folic acid. So you're supposed to be on folic acid for 3 months prior to conceiving. Okay. All right. Anybody who's going to get pregnant should be on the prenatal vitamin. The most important thing for egg quality is a supplement that's called CoQ10. CoQ10 is made in two different forms. One is called ubiquinol, and the other is called ubiquinone. All right. Ubiquinol is the form that your body naturally uses CoQ10. And if you're using ubiquinol, it's 400 milligrams a day in a divided dose, or 200 milligrams twice a day. If you're using something that has ubiquinone as the source of CoQ10, you need a little bit more because your body has to convert that, and that's fine. You just have to make sure you're getting enough. It's 600 milligrams, and that's 300 in the morning and 300 at night. I do think that CoQ10 is the most important supplement you can take for egg quality. Probably next most important thing is some omega-3. It's fish oil. If you're going to get omega-3 or fish oil, make sure you get the one that says that it's odorless or burpless, because literally what they do with this omega-3, with this fish oil, is they take a sardine and they wring it out and get the oil from it. And if you burp that thing up, you will probably never take that supplement again because it is noxious. You won't even want to be in the same zip code with it. The ones that are odorless or burpless are either supplements that are compounded with maybe a little natural lemon oil, so that if you burp something up, that it's lemony instead of fishy, or that are not absorbed until they get into your small intestine instead of your stomach, so that then you don't kind of burp it back. Fish oil is number 2. A number 3 thing, or really number 4 if you're counting the prenatal vitamin, is, believe it or not, a little melatonin. Melatonin, we know, controls our sleep-wake cycles. It's something that you might use if you're jet lagged. It's something flight attendants use. It's something that you can use for sleep periodically if you need it. But we do know that healthier eggs have higher melatonin levels inside the fluid that is in their in that follicular fluid. So when we look with the ultrasound and we see the follicle, the fluid that's in there along with the egg, higher levels of melatonin. So 3 milligrams of melatonin at bedtime helps with egg quality. I think those are probably the easiest things. And those are part of the basic fertility protocol, evidence-based protocol for egg quality. Now, if you have diminished ovarian reserve, if you are over about 40 years old, there are a few other supplements that you should add to that. And I am happy to send you the list if you would like to just message me here on Instagram at RandyFinkMD, or hey, buy the book. It's a really good book, actually. I think I did a good job on it. So just a little plug there. Hopefully that's helpful. And let's see. Hi to Zamanira Hema, I think is what that says. I'm not quite close enough. I've got some spots on my glasses. Hi to Evie. So Z asks, how long after a C-section can you go for a retrieval? All right. Well, so, you have a C-section, you have a scar on your uterus, and that scar has to heal. You've got some general inflammation and all kinds of stuff that's going on as your body is returning to normal. What's really amazing is that when you have your C-section, let's say you have your baby, and then you go back to your OB for your postpartum visit, let's say it's 6 weeks later, your uterus, which had been this big before, to be able to house your baby is now back down to the size of a lemon. It's amazing. It's really an amazing organ. So at the 6 week mark, in most cases, the body has recovered. So I'd give a little extra on that, give it 8 weeks, then maybe 12 weeks. In my opinion, I would say 3 months is probably a good thing, but we don't want you to be breastfeeding because the medications that we use for ovarian stimulation will have an effect both on breast milk production and are secreted into the milk. And those are things that we don't want going to the baby. So if you're not breastfeeding, I'd say 3 months. Now, there may be other scenarios when, let's say, somebody has some kind of emergency and they find out that, oh, they need to have some surgery or they have to get a chemotherapy or something, and it's 1 month after. Gosh, we could do it at any time if you really needed to. But the truth is, if you want to kind of give it the best shot, I'd say realistically 12 weeks and without breastfeeding. We've got about 10 more minutes left here on Fertility with Fink. Thanks so much for being here. It really means the world to me, and I hope it is as meaningful to you that we can be here together tonight. Oh, my Glenda. Hello, Mrs. Villarreal. Nice to see you this evening. Kate Balke, thank you for being there. Okay, Mrs. V says, I just turned 41. Really, because I just turned 21. That is crazy, right? Boy, that is just crazy. Anyway, I just turned 41 and I think I'm experiencing perimenopause. Should I still do a modified natural transfer? My cycle's been all over the place and the periods are later and shorter. Okay, so what is perimenopause anyway? Perimenopause. So menopause is the point at which you're all out of eggs. You're not making any more estrogen. You're not having any more periods for a year or so. That's menopause. Perimenopause is when you start going through those hormonal changes, and it can be anytime, quite honestly, in the 15 to 20 years before you actually go through menopause. Those changes can start to happen as early as 30 years old. Certainly by 35, many people are starting to get some of those perimenopausal type changes. So it's a very normal kind of part of life. But I would say that, if your cycles are irregular, if things are not normal and predictable, well, if you're doing a modified natural transfer, we're giving you medication to make sure that you're going to ovulate. And we're checking those hormones. We're still, just because it says natural doesn't mean that we're not, really intervening. We're checking all the hormone levels. We're doing everything to monitor you. But some people will end up with very short luteal phases, or some people will ovulate kind of at the wrong time, prematurely. If things are going awry and you're not confident in your body's ability to have a natural cycle, there is no harm, there is no downside, there is nothing wrong with doing a medicated cycle. There is no shame in it. There is nothing that is worse about it, because again, in the United States, still the majority of frozen embryo transfer cycles are indeed medicated cycles. They are at least equivalent. So I would say, if you're not so sure what your body's doing there, it might be better to think about doing a programmed cycle or a medicated cycle. Thank you, Mrs. V, for the question. Kauser asks, I have hypothyroidism, and I'm taking 88 micrograms of levothyroxine. I also have Hashimoto's, and my ANA is positive. What precautions do I need to take for successful implantation? I got an HCG wash and intralipid. So yes, those are good things that you can do there. So we got a couple of different things going on here. The thyroid gland here, right, lives in your neck and controls your body's metabolism. When you have hypothyroid means that the volume knob on your thyroid is turned down a little too low. So you need your metabolism turned up just a little bit. So you're getting some thyroid medication in order to be able to do that. Hashimoto's is when your body creates an autoimmune response against your own thyroid gland. And that is one of the more common reasons that folks end up having hypothyroidism, because their immune system ends up attacking the thyroid. The fact that you have both Hashimoto's and that your ANA is positive, those are things that we look at as immune markers. That means that we know that you have an autoimmune response. You've got your immune system is doing something that it ain't supposed to do in your body. And that absolutely can contribute to things going wrong. It can contribute to infertility. It can contribute to inflammation. It can contribute to issues with embryo transfer. So what can you do? Well, you're doing a couple of things there. The intralipid is very helpful for potentially what's known as natural killer cells. The HCG wash turns up the receptors for pregnancy in the lining of your uterus. So a couple of things that I'd feel pretty strongly about for you with the positive ANA and the positive antithyroid antibodies would be, one, some prednisone, so a little bit of steroid, and I would also add the drug that we call low-dose naltrexone. Low-dose naltrexone increases your body's stimulation of endorphins. And when your endorphins go up, your immune system gets regulated. So I would say prednisone is a must, and low-dose naltrexone sounds like a really good idea for you. A special hello this evening to Angelina Foxy up there in Minnesota, who was able to join in here. Thank you so much for being here. I see some beautiful pictures of Angela and her baby, and I am very proud to say that I had a part in that. Thank you very much. And I appreciate, Angela, you sending me those pictures. You know what? Send me another one and I'm going to post it tomorrow. How about that? Good deal. Well, folks, we're going to be running out of time here this evening, but let's see if we had one other thing over here. I think I got them there. So, man, it is so nice to see everybody here. And I hope that you will join me again next week. Tuesday at 5 o'clock Central Time is really the time to be here. And we do this every week, and most importantly, I think, is also the 5:30 Fink, Fuzzies with Fink. Please ask your friends to join, even if it's only for a couple of minutes there, so that we can all stand together as one community and send out all those positive vibes. Big hugs and kisses to everybody. This whole fertility business is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite it together. Every step forward with love and with kindness. Do something to change somebody else's life, would you? Just try to make nice. And every step forward with hope, knowing that tomorrow is a new day full of all new adventures. If I didn't get to your questions tonight, please feel free to email them to me. And that's ask fertility with Fink at firstfertility.com. Ask fertility with Fink at firstfertility.com. Until next week, I am here in Panama City, next week back in Pensacola. Dr. Randy Fink saying thanks so much for being here, and good night.